Okay, welcome everyone. My name is Christy Greeley. I am the Cystinosis Research Network Vice President of Research and Executive Director, and the next segment of our program for today is the research updates that we're presenting. We have a variety of clinicians and researchers who are going to do brief updates on sort of a variety of topics. We have some new clinical trials, some research projects, and other updates.
Good morning, everyone. It's great to be here. I want to thank CRN for inviting me, especially Christy Greeley. This has been an incredible few days. Just been great to be here. Today I'm going to talk about the Cysteamine Nanowafer, which we hope will be a potential therapeutic intervention for corneal cystinosis. I just need to disclose that I'm a consultant for a startup that's really driving this forward, Corneal Cystinosis, Inc. So just a quick overview about the cornea. What is a cornea? The cornea is more than just the window to the front of the eye. It is the major focusing element of the eye, and it is incredibly strong. It's only 500 microns thick in the center portion, but it has this incredible tensile strength. And when you think about it from an evolutionary standpoint, it has to be. It's protecting the contents of your eye. It's avascular, which is great. It has to be to have the optical properties for you to be able to see, but that's bad for you, for us, because the oral medication, oral cysteamine, doesn't get into the cornea. It's got three major layers. The epithelium, which is the outer layer. This big layer here is called the stroma. It's about 90% of the cornea. And then the endothelium is this little monolayer here that's crucial for pumping aqueous, the fluid in the front of the eye, out of the cornea to keep the cornea clear. So these little black dots, I don't know if you can see that on the slide, black dots here, white dots in this confocal image, are the nuclei of the keratocytes. And the keratocytes are the collagen-producing cells. And the collagen is really what confers the clarity of the cornea and the transparency of the cornea. And the keratocytes are the site of the crystine accumulation. So we all know that corneal crystals, cystine crystals, are a pathognomonic finding in all patients with cystinosis, whether you have nephropathic or juvenile or ocular, everybody has corneal cystine crystals. And this is a progressive disease. It starts out in infancy. You can see corneal crystals around 16 months of age, and by the first decade, your cornea becomes packed with crystals by about 10 to 12 years of age. And then in that second decade, you start getting light sensitivity. And then it's not until the third and fourth and fifth decade we start seeing complications, long-term complications from those corneal crystals, including blood vessels growing in and scar. We call that neovascularization. And up until recently, we really haven't had a good understanding of how we get from the top picture to the bottom picture. And that all changed when this knockout mouse model that Dr. Cherki described was created. And the mice have elevated cystine levels in all tissues, including the cornea. And our goal was to use this mouse model to better understand the disease process. How do we get from this photo to this photo? Now, this is slit-line photos of a mouse, a knockout mouse. And you can see these little arrows point to, I don't know if you can see it on the screen, they're cystine crystals. So this is in a 3-month-old mouse, and this is in a 1-year-old mouse. And this is very similar to what we see in humans in their 30s and 40s. You can get corneal scarring. So our goal was to use this mouse model to better understand the pathophysiology, the disease process, and to use a mouse model to screen for novel therapies. So what was our approach? We decided to use confocal microscopy, which is high-resolution, real-time corneal imaging. And this photo is just a human sitting in front of a confocal microscope, and we just substituted the human for the mouse. We sedate the mice, and we image their corneas. And the benefit of this is you don't have to sacrifice the mice to follow these corneas over time. So you get fast, real-time, high-resolution, 3D reconstructions, right? This is a histologic slide. You got to sacrifice the mouse for that. And this is a confocal image. And so this epithelium is this here, stroma is here, and the endothelium is here. So that's kind of our approach. So the first thing we wanted to do was follow a bunch of mice over time. So we did in vivo confocal microscopy at different time points at 4, 6, 8, and 10 months, and we demonstrated that indeed crystals do accumulate like in humans over time. And this is just a 3D reconstruction of the crystals in mice. And we know they start out in mice posteriorly, they move anteriorly, and in humans it's the opposite. It just turns out that in humans, most of the keratocytes are on the top of the cornea, and in mice, most of them are in the posterior. But it's essentially the same pathophysiology. So why do these corneas fail with time? We wanted to have a better understanding of why. What are the crystals doing to the keratocytes? So we sacrificed the mice and took their corneas and did what's called ex vivo confocal microscopy, and we did it at different time points. And we were able to demonstrate that the normal architecture, these are the keratocytes, is a real important architecture like a chain link fence that these keratocytes assume to keep the clarity of the cornea. And with time, that architecture starts to change. You can see that the keratocytes at 5 months are starting to collapse, and you see these highly intense staining cells that increase over time. And turns out that those cells are inflammatory cells. CD45 cells co-localize with these intense cells. So this is at 7 months, and this is at 10 months. So as those mice get older and the cystine crystals stick around in the cornea, they induce an inflammatory response. And the problem is inflammation is horrible for the cornea. That's another reason why the cornea is avascular. Blood vessels bring inflammatory cells. And this is just a confocal image of the endothelium. Remember that endothelium is that monolayer that is crucial for pumping fluid out of the cornea to keep it clear. And the endothelium has this classic hexagonal cellular structure, and then they have these interfaces between the cells that prevent fluid from coming into the stroma. And what happens, you see healthy cells here, and where there are crystals, you have cell loss and scar. So what happens is, this kind of explains why the cornea goes from being clear to cloudy. Once these endothelial cells are lost, cornea becomes thickened and cloudy. And so this slide just gives you sort of an idea of what's happening at 3, 7, and 12 months. You have increased corneal cystine crystal accumulation, and then it goes down. And as it goes down after 7 to 12 months, you have keratocyte death. The keratocytes die, inflammatory cells come in, and you go from having a normal cornea to a scarred cornea. So where are we now? We are fortunate enough to have a therapy for corneal crystals. Cysteamine is the only FDA-approved treatment in the United States. You all know that it requires hourly dosing. And one of the challenges is, obviously, you know, that creates some compliance issues. And there are some side effect issues for some folks who can't tolerate the preservative. The preservative is not only a preservative, it's a surfactant. A surfactant is used in drops to help improve penetration, and what it does is rough up the surface of the epithelium. It also is unstable. So you know that you have to throw out that drop after a week, and the reason you have to do that is because with time, when the bottle is opened and is exposed to oxygen, the arrow is supposed to represent oxygen, it goes from being an active form to an inactive form. So cysteamine is a monomer, and when it's exposed to oxygen, it dimerizes. It forms this disulfide bond, and it becomes inactive. So please, 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 when, after a week, after 7 days, throw that bottle out, go to the freezer and get another one. Don't hang on to it, because you're just putting in a drop that is more inactive. So many patients ask, why do I have to put these drops in every hour? Well, there's some fundamental challenges to ocular drug delivery that make that so. So 90-95% of the drop that's here ends up in your nose, okay? And from an evolutionary standpoint, again, the eyes evolved to being uniquely impervious to drugs, to anything. really. And that has to do with the anatomy of the eye, the blink reflex, your tear. Your tears are incredibly complex. So these 3 layers of the tears, and the mucus layer has this glycocalyx. They're like seaweed that basically pulls everything from your surface down into your drainage system. And then the way the cornea is designed, there are tight junctions in the epithelium that prevent penetration of drugs. The surface is lipophilic, okay, fat-loving. The stroma is hydrophilic. Cysteamine is very hydrophilic, okay? So once you can get into the stroma, it's great, but you have to get through this outer layer, okay? So that's another reason why you have to have benzalkonium chloride. So there are inherent problems, barriers to bioavailability. Bioavailability is just the ability, the active form of the drug to get into the tissues to have its effect. This is just a kind of a complex slide. I'm not really going to spend a lot of time on it, except to say that with drops, you have this peak and valley drug delivery. So drug concentration versus time, you instill a drop, and you get this big peak where you have, some of toxic range, and then you have this fairly narrow therapeutic range, and then you're subtherapeutic. With sustained release drug delivery systems like a drug-eluting contact lens or an ocular insert, you got a big improvement on that. So you have less toxic range and greater therapeutic range. What you really want, the gold standard, is this controlled release drug delivery system. And that's really what we're working towards. So what is an ideal ocular drug delivery system for cysteamine? Well, as I said, you want a controlled release drug delivery profile. You want something ideally that's biodegradable, biocompatible, and you want ideally to have the material to be commercially available. You want it FDA approved. You want your material to enhance the drug stability, and you want it to feel good on the eye. The eye has more nerve endings than any other part of the body. So anything you stick on it, it's got to be comfortable. So this is where this guy comes in. He's my collaborator. His name is Dr. Ghanshyam Acharya. He is a brilliant expert in biomaterials, biopolymers, and he created this thing called the Nanowafer. And it is a hydrogel. It's a polyvinyl alcohol material, which is FDA approved. And it's about 80 microns thick, and it's a couple millimeters in diameter. And it's clear. You can see through it. And this is a little cartoon that just shows that in that little nanowafer, these drug reservoirs, and the cysteamine is instilled in the drug reservoir. And once it hits the eye, it starts to dissolve. And the beauty of this is just a couple more images. This is the top image is just an atomic fork microscopic image. This is just the images of the reservoirs filled with fluorescein. And this is just a little cartoon that shows that as soon as it sticks on the eye, it starts to dissolve and release the active form of the drug. And you don't have to put it, you can design it to have it put on your cornea, so you stick it on your cornea before you go to bed, or you can put it on below your cornea. You can put it on the inside of your lid. There's a lot of flexibility in terms of how you design this. This was a study, a really, really important study. The whole problem with drops is, like we said, you put the drop in, and a couple minutes later, most of the drop is gone. This is just a study looking at fluorescein drops in the mice. So this is an untreated eye, and this is at time 0 where the drop is instilled, little fluorescein drop. 5 minutes later, there's a lot less. 10 minutes later, and 15 minutes later, there's essentially no drop. And that's another reason why you have to keep instilling these drops, and that's a bioavailability barrier. This is where we put the nanowafer on, time 0. And this nanowafer just has fluorescein instilled in it. And you can see that after 1 hour, you still have fluorescein on the cornea. After 3 hours, there's still a lot of fluorescein. 5 hours, 24 hours, and 48 hours. So this is one way of overcoming the bioavailability. You just have to increase the contact time of the drug onto the surface of the eye. This is the other really, really important slide. So we talked about the fact that the drug is unstable, exposed to oxygen, it becomes a dimer. We were able to demonstrate that the cysteamine nanowafer over time is stable. So the blue is the stable monomer, the red is the dimer, the inactive dimer, And this is over weeks, so 10 weeks, 12 weeks, 14 weeks, 16 weeks. The drug is stable because it's sequestered from oxygen. Only is exposed to oxygen once you hit the eye. And this is just demonstrating the application of the nanowafer onto the surface of the eye of the mouse. It's at time 0, 2, 10, and 20 minutes, and you can tailor and you can customize the nanowafer to dissolve at different time points. And because it's made of PVA, polyvinyl alcohol is the stuff that's in lubricated artificial tears. It feels good. It has a lubricating effect on the eye. This is just a study that we did to show that it's safe to the ocular surface. This is baseline. This is just bright field lamp and fluorescein photography. And this is after 4 weeks of applying a nanowafer daily. And there's no evidence of any damage to the surface of the eye and no staining. The eyes are quiet. This is a drug escalation study that we did. So we looked at nanowafers of different concentrations of cysteamine from about 2 micrograms to about 20, and at 15 micrograms, a nanowafer caused corneal clouding, so we chose 5 and 10 nanograms nanowafers, and then we instilled those nanowafers daily over a month, and we were able to demonstrate that with a 10 microgram wafer was superior to 5 microgram wafer in terms of reducing corneal crystals. So we took those 10 microgram nanowafers and we applied them to the cornea daily over a month, and we were able to demonstrate compared to eye drops, twice daily eye drops. So it's a 10 microgram nanowafer and a 44 microgram drop daily total dose. And we did baseline corneal crystal volume, and then a month later measured the corneal crystal volume in the mice with drops versus a nanowafer, and we were able to show that the nanowafers significantly decreased those corneal crystals. So that was in vivo confocal microscopy. We also did mass spec, measuring the total cystine content at baseline. We also did just a blank nanowafer, compared the total cystine content in drops versus the cysteamine nanowafer. And then finally, there's a lot of issues with irritation with the drop, and we wanted to demonstrate. We were hoping that the nanowafer would be less irritating to the eye. That's one of the concerns for the FDA, that it might irritate the eye. So we applied drops to the surface of mice for a month, twice a day, and then applied a cysteamine nanowafer daily, and compared pro-inflammatory cytokines in tears. And I'm sorry, the little key is not available, but green is the drops, and the blue is the nanowafer, and you can see that there's just less inflammation in the tears. So, in summary, this is a proof of concept. This is the first steps in moving toward a clinical trial. We think that we've demonstrated improved drug stability with the nanowafer. We hope that it has improved therapeutic efficacy. We hope that this is going to be a daily treatment, and that we can improve compliance and hopefully minimize inflammatory response. And we think that this is rapidly translatable to human clinical trials. My collaborators are, as I said, Dr. Ghansham Chaira. I'm indebted to his collaboration in this project, as well as Dr. Jamie Jester and Dr. Brianna Lee, who are at UC Irvine. And I'm indebted to Cystinosis Research Foundation for the support of this research. Thank you so much.
Thank you, Dr. Simpson, for that update on the nanowafer work. It's really incredibly promising, and we're grateful for your dedication to our community. Thank you. So our next presenter will be Dr. Elena Levtchenko. She's actually going to be updating us on 2 different projects. One is her work in developing a zebrafish model for studying renal disease and drug treatment in cystinosis. And then she's going to tell us about successful fertility treatment in a male patient with cystinosis. So welcome, Dr. Levtchenko.
Morning, everybody. Let me first thank Christy and Jeff for inviting me here. My name is Elena Levtchenko. I'm coming from Leuven, Belgium. It's really my great pleasure to be here and to be a part of this community. So as Christy told, I'm going to update you on two different projects, and one project is about zebrafish model for studying the disease mechanism and treatment of cystinosis. So why we decided to develop a zebrafish model? This is actually for many reasons which are listed here. The zebrafish you see here, this is a very nice small fish. It's actually not the adult fish, it's a larva. They have a very rapid development, and you can develop a lot of embryos in a short period of time. And these embryos are transparent, so you can see the organs, and you can label fish with different fluorescent dyes and examine them under the microscope. The cost is quite low if you compare it with mammal models like a mouse or a rat. We know the genes of the zebrafish very well, and there is plenty of techniques to knock out the genes or to edit the genes. So this means that this model is quite suitable, and it is already used for studying different diseases and also different kidney diseases. So here you can see this fish again, and when you think about human kidney, we have about 1 million nephrons in the kidney of the human. The zebrafish larva has only 2 nephrons. You can see them here. 2 glomeruli which are fused in the center, and they are followed by the tubular system, which is very much resembles human tubular segments, which are followed to the pronephric duct. So a very simple organism with 2 nephrons, easy to study and quite cheap. So for generating cystinosis zebrafish, we purchased heterozygous fishes from the European zebrafish resource. And this fish had heterozygous mutation in the cystinosis gene, and actually this is the same mutation we find in patients with infantile cystinosis. And so we grew these fishes in our aquarium facility. We crossed the heterozygous papas and mama fishes, and we generated homozygous baby fishes, and these fishes were examined for the phenotype. And here you can see the comparison between cystinosin protein of the fish and cystinosis protein of the humans. And of course, we think that we are much more complicated and complex organisms compared to the fish. However, when we compare the genetic background, 60% of our genes are completely identical to the zebrafish genotype, and 80% of the genes are very similar. And this is also the case for the cystinosis gene. So you see this is a mutant amino acid which we actually created in the zebrafish, I'm sorry. And this is the same mutation that we find in the patients with cystinosis. It's a mutation that generates a truncating protein. And this protein would leak to lysosomal targeting motif and will lead, at least in humans, to the infantile cystinosis. So we started to test this fish, and of course our first criteria to tell that this fish really have cystinosis was to measure their cystine. And you can see here that this fish really accumulate cystine in the fish lysate. And the interesting thing that was that when we applied cysteamine to the swimming water, and this is important because the small fishes until 6-7 days post-fertilization, they are not eating, they are not swallowing, so the cysteamine has to penetrate through their skin. And you can see a very nice decrease of cystine accumulation when these fishes were incubated in cysteamine water. We also tested cystine in the organs of the 8-month-old adult fish, and you can see that also in the adult fish we see very pronounced cystine accumulation. And interestingly, the kidney was one of the organs which accumulated the highest amount of cystine. So another phenotypic characteristic of this fish, it was a higher mortality rate. And you can see that also this phenotypic feature could be improved by cysteamine incubation. So when you incubate these fishes with cysteamine, there will be less dead fishes compared to untreated fishes. Another thing which was interesting that cystinosis larvae had quite some degree of the deformities, and here you can see the normal fish, which are very nice, straight, and this is slightly deformed, a little bit odematose CTNS fish, but there were fishes which had much more pronounced deformities, as you can see here. And this is a fish which was generated by using morpholino, so it's a technique to bind their CTNS messenger RNA in the fish, and this led even to more pronounced deformities than this genetically modified fish. Another feature of cystinosis, which is very characteristic, and this is one of the reasons why cystinotic proximal tubular cells, but also other organs get atrophic, is increased rate of cell death or apoptosis, and also this feature was increased in the cystinosis fish. So here you can see the acridine orange assay, which indicates apoptotic spots, and you can see that there were many more apoptotic spots in the cystinosis fish compared to the wild-type fish. And also this feature of cystinosis could be improved by the lower dose of cysteamine, as you can see here, and it was actually increased upon higher doses of cysteamine. We also look microscopically at the kidneys of the fishes, and this is a little bit complex electron microscopic images. So in their kidney filters and glomeruli, you have cells which are very important for the maintaining of glomerular filtration barrier, and they are called podocytes. And these podocytes have food processes which reside on the glomerular basement membrane, and they actually maintain glomerular filtration barrier, preventing proteins and other big substances to pass through the glomerular basement membrane. And we know from many other proteinuric diseases that when these cells get affected by the disease, they retract their food processes and they start to lie with their cell body, as you can see here, on the glomerular membrane, and this mostly leads to proteinuria. And when we look to the kidneys of the cystinosis zebrafish, we found these fused or phased food processes of the podocytes, and it could be also quantified, and this is really the feature of the glomerular disease in this fish. We also looked at the proximal tubules of the fishes, and here you can see the images of the wild-type fishes and the cystinosis fish, and you can see here then their cystinotic fishes had very huge pronounced lysosomes, and it's also what we see in the proximal tubular cells of their patients and also of the cystinosis mouse. And these lysosomes were also concentrated around the nuclei, and this again the feature that we see in the human and in the mouse kidney fish. Again, this could be quantified, and this was also clearly statistically different from the control fishes. We did also some functional tests, and these are tests to study the kidney function. So in one of the tests, we injected the fishes with a high molecular weight dextran, labeled here in red. And this dextran in the healthy fish would stay in the circulation and will not be lost into urine. When circulating, this red dextran will penetrate to the retina of the fish, and this is a very nice region that you can measure by the fluorescent microscopy and quantify. And you can see clearly that after 24 hours, wild-type fish had a lot of this red dextran in the eye, while it was almost completely lost in the cystinosis fish, meaning that these fish lost this protein through their kidneys. We also evaluated the reabsorption of low molecular weight dextran, which is here labeled in green. This dextran can be passed through the glomerular barrier because it's a small molecule, but it should be reabsorbed by the proximal tubules of the fish. And you can see here that the normal fishes, healthy fishes, they could reabsorb this green dextran, while cystinotic fishes could not. And this is a kind of the surrogate for renal Fanconi syndrome, because patients with renal Fanconi syndrome also lose low molecular weight proteins, and this was also the case in this fish model. So we know that scavenger receptors megalin and cubulin are the proteins which are responsible for the proximal tubular reabsorption of the proteins, and therefore we stained our fish kidneys for these molecules, and you can see that while megalin was highly expressed on the brush border of the wild-type fishes, this expression was much lower in the fishes with cystinosis, and actually it was not on the brush border, but it was under the brush border. And again, this is a feature that we see in the proximal tubules of the cystinotic kidneys in humans and also in the CTNS mouse. And this is probably the reason why these fishes cannot reabsorb low molecular weight proteins. So altogether, we see a lot of features that are present in human cystinosis and also in the mouse model of cystinosis in this very easy and cheap model zebrafish. So how can we use this model? One of the things where zebrafishes are widely used is to test different drug treatments. And this is what we are actually doing now. How are you doing it? First of all, of course, you have to see whether the drug is not toxic for the fish. So you have to assess mortality, teratogenicity, development effect of the drug. And of course, we need to know whether the drug is efficient. And we have a very good readout possibilities like cystine accumulation, like the rate of apoptosis, oxidative stress. I didn't show you the data, but also the fishes demonstrate increased oxidative stress rate, proteinuria, or endocytosis. And we tested quite some compounds, and not of them were successful. I just show you one example of one compound. So here you can see that this compound was added at different concentrations after 2 days post-fertilization. You can see that in wild type it was not toxic. We did the same in cystinosis fish, and again this compound was not toxic, so it was good for us. For this compound, we tested the deformity, and you can see that this compound improved the deformities present in the cystinosis fish. Again, good sign. We tested the rate of apoptosis, and this compound was also quite efficient to decrease the apoptosis rate. And this compound is very interesting that it acts beyond cystine accumulation. So there was no effect on cystine, but it was also the idea because it interferes with a different pathway than cystine accumulation. So we are going on with the different compounds to test their efficiency on the degree of proteinuria, apoptosis, and other disease features of the fish. So to summarize in this project, I think I have shown you that cystinosis zebrafish demonstrates major disease features of cystinosis, such as accumulation of cystine, increased apoptosis, increased oxidative stress, glomerular and tubular disease. The good news is that these fish are responsive to cysteamine and other pharmacological treatments, and this model, therefore, looks quite suitable for studying drug therapy in cystinosis and also the pathophysiology of the disease. So another completely different project I'm going to highlight in few next slides is treatment of fertility in male cystinosis patients. So we know that cystinosis females are fertile. We know several females who gave birth to children. However, male cystinosis patients are so far considered to be infertile. And we know from the early reports in patients who were untreated with cysteamine or treated at later age that these patients get testis fibrosis and quite low levels of sexual hormones. However, patients who are treated from the younger age, and it was a report by Martina Besau, who worked in our group quite recently, we have found that despite of this treatment, still many patients had, male patients had delayed puberty, but many of them still could reach normal sexual maturation. And the sex hormones, when we tested them, were also normal in about 30% of these patients. We also did a testis biopsy in one patient, and it showed normal rate of spermatogenesis. However, when we examined the ejaculate of these 7 males, none of them had sperm cells in the ejaculate. However, the fact that their spermatogenesis was present in the testis biopsy was quite a positive sign and made us thinking that the assisted fertilization should be possible in these young males. And now I'm going to present you a case history. So this patient presented in our clinic when he was 4 years of age and quite late for the diagnosis of cystinosis. And at that age, cysteamine treatment was started. He reached end-stage renal disease at the age of 10 years and got his kidney graft, which is still functioning at 11 years of age. He got standard immunosuppressive treatment with cyclosporin A, azathioprine, and low-dose steroids. This man had always excellent compliance with cysteamine therapy. He is really an example how you should take cysteamine. He had always very low levels of white blood cell cystine. His sexual development was delayed, as in many cystinotic males. However, at the age of 20, he reached normal tenor stages, which is the stages of their puberty development. And he did quite well. He finished high school. He got the university degree in biology. He is living together with his university girlfriend. He has a permanent position in the biotech company. And at a certain moment, this young couple decided to have children. So he came to our fertility clinic to examine whether it was possible. And just to refresh your memory concerning spermatogenesis, spermatogenesis is a process which is taking place in the testes to generate sperm. It is a very tightly regulated process. It's regulated from the hypothalamus through the anterior pituitary gland through hormones to stimulate the secretion of testosterone and inhibin B by Leydig cells and Sertoli cells, and altogether it results in the generation of normal sperm. So at different stages of this process, things can be going wrong, and this is how we examine these patients when they come to address the issue of infertility. So here you can see the results of the sexual hormones, which were quite normal, and actually he was one of the patients who participated in our early studies in fertility, so we had the levels of the hormones over some period of time, and you can see that actually this was one of the boys with quite normal levels of the hormones. The only thing which was a little bit worrisome is that the testosterone levels were that the testosterone levels were slightly decreasing over the period of time. However, they still were in the normal range, and this was also the same for the other hormones. However, when we examined the ejaculate of this patient, we found no sperm cells, meaning that we had to go on with assisted fertilization. That's what we were doing. So I'm just explaining you a little bit how this process is taking place. So for this assisted fertilization procedure, the female partner of the couple has to be stimulated with hormones so that several follicles will get mature, and this you can see these follicles, they can be aspirated by a needle. At the same time, the epididymis of the patient had to be punctured, and you can extract sperm via this puncture. And fortunately for this patient, it was a viable sperm that could be used for the in vitro fertilization. And then you have this ICSI procedure. ICSI is oocyte sperm injection. So you can bring the sperm inside of their oocyte. And this induces the fertilization, and after the fertilization, the embryo will develop. And mostly at the age of 10-stage embryo, the embryo can be placed back to the uterus of the mother, and the pregnancy can continue. So in this couple, 2 embryos were brought back to the mother, and this pregnancy was successful. And finally, 1 year ago, this couple got twins. And here you can see the twins, and they are doing very well. They are 2 healthy children, and actually this family is extremely happy that it could happen. So now I think this is a very nice story, and I think it gives really perspective to many patients who can get children via this procedure. However, we still don't understand why this viable sperm present in the epididymis of the patient, and actually we did epididymal biopsy in 2 other patients, and they all had viable sperm there. Why it is not present in ejaculate? And there are possible reasons for that we are now trying to examine. For example, the abnormal epididymal environment in terms of fluid and ion composition can disturb sperm motility. You can have abnormal sperm characteristics, making them less viable, for example. The hormones are also not normal in all patients, so this can also be a reason for at least some patients. And possibly cysteamine treatment can, on one hand, protect testes against the fibrosis, but potentially can also can have some negative effect on the hormone or sperm. And there are some studies in animals that suggest this hypothesis. And so now we have a protocol ongoing in our hospital to examine these opportunities, but also to offer the possibility of this IVF treatment for those cystinosis patients who would like to have children. So I'm coming to the end of my story, and I would like to acknowledge everybody who worked with me for many years and is still working now. Our very active patient group in the Netherlands and in Belgium, these people really helped me a lot, and they are always stimulating, and they give a lot of ideas for the studies. I would like especially to thank Mohamed Elmonem. It's a very nice person from Egypt, a Ph.D. student. He was actually the student of Nivin Soliman, and he was the person who developed the zebrafish. Konrad Weiss is working on fertility. For compound testing, we're working with Francesco Emma, Paul Goodyear, Ross Anderson, and Rose Madareu. They developed different compounds that we are testing in the zebrafish. And I would especially like to thank Cystinosis Research Network and eRare for supporting our zebrafish project, and also Cystinosis Foundation Ireland, who gave us a grant to study the fertility issues in cystinosis. And this is another person, a postdoc, who did his PhD in Karolinska on fertility issues, and now he's staying with us to study the fertility in cystinosis patients. And just to wrap up, I would like to show you 2 European initiatives that might be interesting. One of them is European Reference Network. It's an initiative organized by the European Community, actually inspired by the patient associations, and the idea is to have in Europe centers of excellence to treat rare diseases. And cystinosis is one of these diseases, and the idea is that patient would be able to identify the centers on the European map. They will know the name of the physicians, and also their role of the centers would be to educate themselves and other physicians treating the patients, to also to provide cross-border care. And EU is also going to invest in the telemedicine, and this is how we try to overcome the problem that we discussed yesterday of patients being isolated and doctors not having a lot of information on rare diseases such as cystinosis. Another initiative is the registry on rare diseases, and cystinosis is a big part of this registry. It's a radical registry which is has its basis in Paris, and now we have about 400 cystinosis patients included in this registry. It's a very detailed database, including genetic data and a lot of clinical data, and the idea is also maybe to have biobanking in the future to understand more their natural course and the effect of different treatments applied in cystinosis. Thank you very much for your attention.
Thank you to Dr. Levtchenko. CRN is very proud to support the work of her lab, which does excellent work, and the information you've just given us about male fertility is very encouraging. He's going to give us an update on clinical studies with Procysbi. What did we learn in the end of an era? Dr. Langman.
Well, I'd like to, again, thank the Cystinosis Research Network, Christy, Jeff, and the entire board for allowing me to come many times to these meetings. And for this, Christy asked me to sort of talk about what we've learned in the many clinical studies with Procysbi over the last few years. And I entitled it End of an Era, and I'll discuss that at the end. So my relevant financial disclosures didn't change overnight. And I wanted to sort of come back to why we even began to think about clinical trials in cystinosis with a new agent. And I think that we all recognize that the development of cysteamine by the group that included Jerry Schneider, Bill Gall, Jess Taney, and others was life-saving to the population of our patients with cystinosis. But in doing so, it had always been used clinically, observationally, and provided incredible, important historical, anecdotal, observational data, but it had never been really subjected to well-designed clinical trials to try to answer additional questions. And that's not a fault of anyone, it's just the way the drug developed and was life-saving. So at some point, we needed to begin to ask questions that could be in a formal clinical trial. So just to remind you, this is one of the slides or the concepts that Josh Zawitsky asked you to remember yesterday is that cystine gets into the cell and the CTNS box transports it out when it works normally. In the presence of a dysfunctional CTNS protein, which causes nephropathic cystinosis, you know that the cell accumulates cystine. That life-saving agent, cysteamine, it gets into the cell easily, forms a mixed disulfide reaction with the cystine in the cell, and then goes out through the PQL-C2 transporter, another member of the cystinosin family that is activated by this sulfhydryl disulfide compound. And in doing so, we can titrate the reduction of the cell cystine to any particular number we want. And in the marketed products of both Cystegon and Procysbi, using the biomarker assay that we had used until more recently, we wanted values below its 1 nanomole per milligram protein. So there's no question in this cartoon that I adapted from Paul. Cysteamine absolutely lowers intracellular cystine levels when it's given to patients. Shown here, if lowers it to about 10 to 20% of that baseline value. And in early life, when cystinosis is diagnosed in young infants, it's very easy to do and keep that intracellular cystine at a normal rate, rather a low level. However, what's the problem with the use of that every 6-hour drug called Cystegon, or immediate-release cysteamine? Well, the only thing wrong with it is that life happens, and it's very hard because of lifestyle, adolescence, and that adult physicians don't often know to continue the drug post-kidney transplant for those levels to remain at the low levels we'd like for highest degree of efficacy. And so it became clear that it might be advantageous for all these reasons to try to develop a drug that wasn't necessary every 6 hours. And in addition, there seemed to be, in addition to the every 6-hour dosing schedule, and I don't have time to discuss the potential of what happens when you have disturbed sleep on a repetitive basis, there clearly were some side effects, but compared to no treatment, they were accepted for a long time of GI distress, nausea, and vomiting. We all are aware of the offensive breath and body odor, and the need often for the concomitant use of proton pump inhibitors to offset the GI side effects, and PPIs themselves have some long-term difficulties. So as a result, in multiple analyses that were done, that about 70 to 80% of patients at the time of older childhood, adolescence, really were not adherent to this every 6-hour schedule. And in the medical session yesterday, we heard that if you take it less than every 6 hours, it really is not going to be very efficacious. So this is just the latest publication from Spain, from Gemma Araceta. And what she showed was that compliance drops off dramatically after about age 11. And this is just consistent with what we all understood. Okay, so I want to thank, at this point, patients with rare diseases, in this case cystinosis, and really the Cystinosis Research Network for advertising all the clinical trials that were undertaken in this rare disease. And were it not for the good nature and willingness to participate in such clinical trials, and hopefully in those that you heard about today from Dr. Cherki as well in the future, we would not be able to provide innovative new therapies for this disease. And I think it speaks to really the need to address continually the unmet medical need for patients with rare disease. So if the clinical goals of substrate depletion therapy were to use that biomarker and keep it very low, and that would optimize at least kidney outcomes, we think, and perhaps other organ dysfunctions, to avoid side effects, which included that gastric acid hypersecretion for multiple reasons, and maybe eliminate the need for chronic usage of proton pump inhibitors, and perhaps change the offensive breath and body odor. So shown here in blue is the typical concentration of cysteamine. When you take in blue the cystagon, it goes up immediately, and by 6 hours it goes down to baseline values. And the difference is with Procysbi, that every 12-hour drug is that there was a delayed onset and release of the agent. Over the 12 hours, it achieved 2 times the 6-hour area under the curve, so it was equivalent. So what's the prior work? I'm not going to go over it in great detail. We already established short-term non-inferiority of Procysbi. Now, a lot of people have criticized us for why did we choose to do a non-inferiority study? Because we chose the very best patients for control of their white blood cell cystine. And so when it's already in the range that you expect, you can't really do better than great. So it really is a non-inferiority that it's as good as the existing agent. And we studied initially 43 patients with that well-controlled white blood cell cystine biomarker. Now, importantly, we're able to do this at a mean total daily dose, which was only 82% of the total daily dose of cystagon. So it was perhaps, in that sense, more efficacious at a lower total dose, but certainly by biomarker, it was non-inferior. And importantly, there were no new adverse effects associated with short-term Procysbi, and perhaps less, as I'll describe. So this is I'm not going to go over it. It was published, just the fact that we did study 43 patients. 41 finished the trial. There were 2 withdrawals from patients at my center, 2 brothers because of a planned orthopedic surgery and the inability to travel after that, not from any drug issues. The baseline characteristics of the patients were approximately age 11 and a half or so. But I want to point out that if you look at their kidney function, if there's a mouse, here it is, that their estimated GFR already was at 67 milliliters per minute per 1.73 meters squared. Normal is somewhere around above 90. So even in the well-controlled patients, they already had kidney insufficiency, and we call this CKD stage 2. And you can see the other clinical characteristics. I only want to point out that in the randomized trial for non-inferiority, which was short-term, we asked patients to stop using their PPIs voluntarily, but they could continue to use it anytime they wanted, and or if they didn't want it, if their physicians thought it would be of benefit to them. And I just want to point out that in this randomized study that when patients were using the immediate release cysteamine, that's marketed as cystagon, 11 patients took 233 pills when they started on the cystagon, and during the time they were then switched off the cystagon to the delayed release cysteamine, now marketed as Procysbi, 2 patients used 51 pills. When patients were started on the delayed release cysteamine at the beginning of that trial, 3 patients used 7 pills, whereas when they were switched back to the immediate release cysteamine, 7 patients used 220 pills. So in total, very few patients used very few pills when they were treated under what became known as Procysbi compared to what is now known as, remains cystagon. So a 98% reduction in pill use. Importantly, and many of the investigators are in this audience, we had a long-term extension study for 2 years. That's also been published. I just want to point out that we studied 40 patients. Pointed out by the arrows are the fact that their height z-score wasn't bad, actually, for having chronic kidney disease. It was just a little bit under a z-score of -1. Their kidney function was very similar in this trial as it was in the previous trial at about 63 mils per minute, CKD2, and their white blood cell cysteine levels were really pristine in 85% of the patients, well below that level of 1. For the length of the study that's shown here over 24 months, their white blood cell cysteine at all times for the group remained below the level of 1 and didn't change over the course of the trial. And the total daily dose necessary of what now is known as Procysbi was reduced significantly compared to that which they had entered on Cystagon, and at the end was about 42 or so milligrams per kilogram per day to maintain white blood cell levels in the optimal range required. Growth was maintained during the period of the study, and for the first time we showed stability of kidney function over a 2-year period in patients that were optimally controlled in their white blood cell biomarker. 2 patients fell out of the study for a kidney transplant. One had started at a very low level of only 15 milliliters per minute and was expected to have a kidney transplant, and the other had a kidney transplant with a planned kidney transplant also in the course of the study. So nothing unexpected. And we also did a formal quality of life study that had been validated for kids, and we'll hear hopefully more about some quality of life issues from our next speaker or so. But importantly, that changing from the use of the every 6-hour drug to the every 12-hour drug, there was an immediate improvement in social, school, and total function on this quality of life, and it was maintained for the 2 years of the study. Physical just missed at 0.054. We were looking for 0.05, and it was just a little bit above. But nobody lost the gain of improvement in quality of life, and I think that's also important. And happily, whatever adverse events were there decreased significantly over the course of the 2 years of study in this group of patients. Now, we did some additional studies, and they were alluded to, I believe, by Niels this morning. One was that in the course of this study, we started to expose patients by sprinkle under 6 years to the treatment with delayed-release compound, now marketed as Procysbi. We studied 14 children under 6 years of age. We showed that there was an equivalence using sprinkle and open capsule for the concentration achieved of the drug. And I called this a pragmatic study. We presented this a year or so ago in the ERA-EDTA study. I believe it's actually 2016, there's a mistake in the year. We studied children at age 4 years in the following characteristics, and you saw that all of these patients had been treated before with immediate release cysteamine marketed as a Cystagon. In the mean value was shown here as milligrams per meter squared per day. And their white blood cell cysteine in general was that, about 1.4, with some a little bit below. Over time, everyone's white blood cell cysteine came to be less than 1. So target values as they switched to the sprinkle with Procysbi. And their daily dose also decreased compared to that required for immediate release Q6 hours Cystagon, just as we had seen in the older children taking the capsules. Importantly, in the extension study that I showed you over 24 months for the older children, 17 of 40 of the patients never required PPI or other gastric acid-reducing therapy, and 23 patients continued some form of it, but only for a total of 60 tablets for their entire 2-year period. In the younger children under 6 years, again, we asked them to, if they were on PPIs, to stop it. 3 of the 14 never required any, actually, when we switched them to the sprinkles, and 11 took 27 tablets over the period of study. So again, it looks like PPI usage in a trial basis could be reduced most of the time. The last study I wanted to talk about are the treatment-naive patients. This was also alluded to by Niels this morning. This was a multinational study performed in Chicago and Sao Paulo. 17 cysteamine-naive patients were enrolled, and 15 of 17 were below 6 years of age. And I wanted to present the data for those less than 6 years old. The starting dose in these treatment-naive patients was increased 10% every 2 weeks until the white blood cell biomarker was less than 1. And we assessed growth parameters as well as treatment emergent adverse events at every study visit for the period of study that I'll show you. So the baseline characteristics, again, for those less than 6, since the 15 of the 17 were very young, was about 2.2 years, 10 were male, and the biomarker diagnosis and entry into the study, because they were treatment naive, was 3.1. At each subsequent visit after the initiation of Procysbi, the white blood cell biomarker was less than at baseline. It immediately went down at week 2 to minus 2.2, to 2.2, and by 18 months of study was below 1. It actually was reduced less than 1 before that, but the study was stopped at 18 months of treatment. And at that time, 77% of the patients had achieved a desired and maintained a desired white blood cell biomarker less than 1. Now, I wanted to go over some of the growth parameters that we studied. At the beginning, standing height was at the 2.5 percentile and increased continually. So at the end of the study, after 18 months, these young children with cystinosis were at the 55th percentile for standing height. Another way to look at that is by height z-score. Their height z-score was negative minus 3.16, very obviously short, and it increased continually, and at the end of the study was 0.11, which was statistically significant. Their weight was at the 3.5 percentile at study start, and was the 33rd percentile at study end. That also was significant. And we're in the midst of using some GFR-based equations to look at kidney function. Now, to be fair, all patients had experienced at least one treatment-associated or emergent adverse event. 12 had a serious adverse event, and 5 had greater than grade 3, which is sort of the top of that mark. All of them were in the first 6 months of treatment, however. And to be fair, one patient in Brazil died of an illness unrelated to the study drug from the outskirts, very far away from the study center in Sao Paulo, that was related to extreme volume depletion that wasn't repaired. And the conclusion of this 18-month study in treatment-naive patients was such patients with cystinosis may be safely and efficiently started on cysteine reduction therapy de novo. So at present, all prospective clinical studies of systemic therapy for cystinosis have ended with therapy. The database that Naprotix will be initiating, I think, is another opportunity to ask wonderful questions of the natural history of cystinosis under whatever therapy is being used. But many, many questions remain unanswered because studies have really only gone on for a very short period of time, have mostly looked important questions at growth, which we, I think, have demonstrated was improved with the drug, kidney function, which has been stable. But many, many long-term questions really need to be answered. And the question was, how will our community find these answers? And I think that I'd ask all of you in the community, both those who are at the patient-based level, as well as those of us at the science and clinician level, to continue to press the existing available resources, including National Institutes of Health by providing grants to ask these questions long-term for some of the longer-term complications. So I thank you for the answer that you provided by allowing us to study yourselves. Thank you.
Thank you, Dr. Langman, for that very nice outline of the clinical trials in Procysbi. Our next speaker will be Dr. Elenberg. She's going to talk to us about chronic kidney disease, dialysis, and transplant outcomes in cystinosis. Please welcome Dr. Elenberg.
So I would like to disclose that this study has been supported by Horizon Orphan Company. Patients with cystinosis develop end-stage kidney disease by adolescence usually and require dialysis or eventually kidney transplant. There is very little data on outcomes of cystinosis patients with chronic kidney disease, renal transplantation, and overall end-stage kidney disease. NAPROTEX, which is North American Pediatric Renal Trials and Collaborative Studies, was established in 1987, so 30 years ago. And it was initially established to capture information on practice and trends in immunosuppressive therapy, so it was only for transplant patients. The overall goal was to improve pediatric care. And then in 1992, the study was expanded to include dialysis pediatric patients. And then in 1994, data collection began on chronic kidney disease patients. So as of 2015, NAPROTEX data has more than information on more than 19,000 children, and these 19,000 also includes cystinosis patients who have CKD, who are on dialysis, and who have renal transplant. Now, what is this database? It's a computer database that all medical centers who take care of pediatric patients who want to be the part of this database enter on regular basis the information about the patients. And obviously patients also give the consent to enter the data. So this study is a retrospective analysis of the data that we have. It included all patients with cystinosis who are on this NAPROTEX database. And this information, the data collected on the cystinosis patients, was compared to other patients who also were on dialysis, had chronic kidney disease, who had transplant. Obviously, certain patients had to be excluded for this evaluation. So we excluded all patients who were non-cystinosis patients, who were potential for the failure of renal transplant, either because of recurrence of the disease that is well known. There are many diseases that are well known that can recur in transplant. So now I will go over each of these registries. So first is CKD registry, chronic kidney disease. There are 117 cystinosis patients with chronic kidney disease that were entered, and they were compared to other patients, 2,109 patients who were entered in cystinosis registry. These were patients after already the other patients who were excluded from exclusion criteria. So most of cystinosis patients, again, number is 117, were entered at age 6 to 12, versus patients who were CKD. The database collected was 34% young patients, less than 1 year of age. Also the race, there is difference. Cystinosis, we know it's mostly Caucasians versus other CKD patients. Growth deficit, there was a significance in growth deficit in cystinosis patients. 67% had a significant growth deficit who those patients who were with CKD versus other patients. And the growth hormone obviously was used more commonly in cystinosis patients. Blood pressure. Overall blood pressure was better in cystinosis patients. And there was something and there is no statistical difference in anemia, in parathyroid hormone in those patients with CKD or erythropoietin use. Now, looking at some other information, looking at age, most of cystinosis patients were about 3 years of age, and the others were 6.6. And again, I already mentioned significant difference in Z-score. Again, patients were shorter than others, had growth deficiency. Calcium, we talked about it yesterday. Cystinosis patients with CKD overall had lower calcium in comparison to patients with other causes. So mean calcium was 9.1 versus 9.7. Phosphate level also was lower, and there is a significance, obviously, between those two levels. Cystinosis patients had lower phosphorus level versus the other patients with CKD. There was no any difference in serum creatinine, hematocrit, hemoglobin, or even CO2 level. Alkaline phosphatase was higher in patients with CKD who had cystinosis versus the other patients with CKD. Time of progression, so the time from the registry to the registration to in this database to end-stage kidney disease was faster for cystinosis patients. They went to end-stage kidney, they needed dialysis or transplant faster than other patients. So in summary of the CKD, there is statistical significance in race at baseline registration, age. Again, cystinosis patients were more than 6 years of age versus the other patients were less than 1. CKD stage, most of cystinosis patients were entered to registry when they were in stage 3. And then cystinosis patients had significantly lower blood pressure versus the other patients. Now, growth was significantly delayed in cystinosis patients, and looking at bone and mineral metabolism, calcium and phosphate were lower in cystinosis patients, and alkaline phosphatase was higher. And cystinosis patients progressed faster to end-stage kidney disease versus other patients with chronic kidney disease. There is no significance in the difference in gender, serum creatinine, CO2, parathyroid hormone level, or anemia or erythropoietin use. Now, moving to dialysis registry, there were 95 cystinosis patients versus the other patients. I just want to point something from this one, that we have more data collection up to 2004 than later. There was a gap in collection, so this is just to mention this. Now, again, baseline demographics. Most patients who were on dialysis, they were at age 6 to 12 years of age versus the other causes. Again, mean age was about 11.9 versus 8, and race is the same as other patients, as other database CKD. Now, what I found interesting, that cystinosis patients were no any different than other patients in the dialysis modality choice. Most of the patients chose peritoneal dialysis. I always somehow thought that cystinosis patients would choose peritoneal dialysis more than other patients, but that's not the case. And again, there is no difference in gender and dialysis modality either. Now, looking at the blood pressure, similar findings that CKD database showed. Overall, normal blood pressure was more common for cystinosis patients on dialysis versus other patients, and diastolic blood pressure also was better. No significance in systolic blood pressure Z-scores, but and there is no significance in anemia or erythropoietin use. the same what already CKD database showed. Now looking at the growth, again, similar data, significant delay in growth in comparison cystinosis to other patients, and the same with the weight. Now, again, looking at growth deficit more significant in cystinosis patients, and cystinosis patients had more common growth hormone use than other patients. Actually, I was surprised because I really thought that cystinosis patients will use much more. It's only 35% of cystinosis patients who are on dialysis were on growth hormone. So this part needs answers. That's not understood really clearly why not every cystinosis patient who is on dialysis, who has growth delay, is not on growth hormone. Parathyroid hormone in cystinosis patients, parathyroid hormone overall was better, was closer to expected normal than other patients. And calcium level, again, proves the same. CKD patients had lower calcium, and the same with dialysis patients. Also, cystinosis dialysis patients had lower calcium. And they had also, I just showed previously, they had phosphorus was not so significantly different. Now, cystinosis, dialysis patient survival is great with cystinosis patients. So this is good news. Time to dialysis termination for transplant, it's the same. Patients with cystinosis are treated equally. They are waiting on the transplant list as other patients. So there is, just to summarize, there is statistical significance in age when patients were entered to dialysis registration. They were older than other patients. Race, again, no change. From like Caucasians, white population is much more common. And cystinosis patient had significantly lower blood pressure, especially in diastolic blood pressure. There is also statistical significance in the growth. For cystinosis patients, there is more growth delay, and calcium and parathyroid hormone levels are lower for cystinosis patients, and dialysis survival is better in dialysis patients who have cystinosis. And there is no statistical difference in gender, dialysis modality. Again, commonly cystinosis in other patients shows peritoneal dialysis, or systolic blood pressure Z-score, anemia, erythropoietin use, level of albumin, phosphorus level, and time from transplant to dialysis, to the transplant while on dialysis. So the last registry is transplant registry. There were 231 cystinosis patients entered in this registry, and they were compared to other patients. There were 2,844 other patients who had kidney transplant in this registry. 91% of cystinosis patients who were in that registry had one transplant, and 9% of patients had 2 transplants. And actually, this data was similar to other patients. So again, this to show that we have more data collected from older data up to 2004, more information on patients, and again, number of transplant I mentioned. Graft survival is not any different from this evaluation, not any different than other patients who have transplant, which is in contrast to the report from Dr. Van Stralen, who noticed that actually patients with cystinosis have longer graft survival. So I cannot speak why there is no difference. I would say I excluded a lot of patients from the transplant list meeting exclusion criteria, meaning those patients who would have recurrence of the disease and a risk for transplant loss when they had an inflammatory diseases or other causes for end-stage kidney disease. Time to first rejection, no any difference between cystinosis and other patients. Significantly, again, different height Z-score. Again, looking back, really very careful attention to growth early on is important. Weight Z-score, no any difference. I mean, there is it's worse for cystinosis patients, and we already know it. So data obtained from 231 patients with cystinosis were compared to 2,844 other transplant patients. There is statistical significance in age at baseline. Transplant registration, cystinosis patients, obviously, they were older. And race, cystinosis patients are mostly Caucasian. And height and weight Z-scores at baseline, cystinosis patient had worse. No statistical difference in gender, graft survival, donor source, living-related donor versus diseased donor, primary transplant, preemptive transplant, dialysis during first week, whether it was used dialysis the first week or not, steroid use after 30 days of transplant, time to first rejection, and number of transplants. There was no difference. So in conclusion, CKD and dialysis cystinosis patients differ from other patients who have non-immunologic causes for CKD and end-stage. Cystinosis patients progress to end-stage kidney disease faster than other patients. Growth deficit in cystinosis patients is significantly worse, and growth hormone is more commonly used. Calcium and PTH levels are lower in cystinosis patients. They have better dialysis survival. But why this is better survival for cystinosis patients, we don't know. It needs to be studied. Transplant cystinosis patients have no difference in donor source, primary transplant versus preemptive transplant, graft survival, or time to first rejection. I especially want to thank Horizon Orphan for sponsoring this investigator-initiated clinical study, and I want to thank Karen Mars, who she's a Naprotex biostatistician who pulled the data from this computerized database for presentation and evaluation. Now, I would like now to tell you already what I mentioned yesterday, that Naprotex, again, which is a doctors-run organization that has this computerized database, we submitted the grant proposal to Horizon, and Horizon approved this proposal. We would like to make a kind of a wing to the Naprotex database that we already have and start prospective entering of data of cystinosis patients. The database will be very detailed, and again, any doctor who has any idea of the research and what they would like to study or what type of information they would like to pull out of this is welcome just to write to Naprotex. We will make it open for everybody to study. Again, it will be a prospective database, so we have very detailed questionnaire. This questionnaire will be answered only by doctors who take care of cystinosis patients and doctors who want to participate in collection. And because it's a very detailed study, again, it will be entered every 6 months, and there are pages of questions that we have that eventually will help us eventually in years to come to understand more cystinosis. Thank you.
Thank you, Dr. Elenberg, for your presenting us with the assessment of the registry database, and we look forward to hearing what comes out of the new studies. Dr. Galina Nesterova. She, I should note, was formerly funded as the CRN Clinical Fellow under Dr. Bill Gall at the NIH, and this morning she's going to be talking to us about bone deformities and cystinosis. Dr. Nesterova.
Good morning, everyone. It's, of course, a pleasure and a greatest honor to be here and to be supported by CRN for so many years and to be part of such exceptional group of people. And I want to congratulate CRN, Christy, current presidents, Jeff, and past presidents for such hard-earned success and continuous progress helping to cystinosis patients and including doctors to be part of such wonderful community. So we spoke briefly yesterday about bone disease in cystinosis patients, but I don't think we can emphasize enough now about this emerging complaint and concern in cystinosis patients. My presentation mostly will be addressing patients pre-transplant, then we first just detect skeletal and bone issues and possible long-term goal to prevent skeletal deformities when older patients with long-term disease are suffering. And again, my presentation mostly clinically oriented. It's based on the retrospective and prospective collection of the data of natural history of cysteamine therapy with nephropathic cystinosis, and now it's becoming partially is a natural history of bone disease, in particular pre-transplant patient with cystinosis. So just a brief definition, which is various types of bone disease and cystinosis. Mostly in the literature is referred as metabolic bone disease because it's multifactorial. Now we recognize it's multifactorial. Before kidney disease, let's say children between age 1 and 12, it refers as Rickets or Fanconi syndrome. And indeed, I think we are now well informed that Fanconi syndrome indeed causing Rickets could be associated with osteopenia, osteomalacia closer to age of 10 and 12. All the patients were defined bone disease such as osteopenia and osteomalacia detected either by X-rays or some other studies. You probably know the DEXA scan and between 12 to early adulthood. During post-renal failure, I'll just mention briefly, it's renal osteodystrophy, could be similar in Rickets by symptoms, but we will not focus today on that. All types of bone disease and cystinosis causing short stature, which is contributing already as a part of a natural history of cystinosis, skeletal deformities, mild to severe, and bone fragility. I think in some literature about decades ago been stating that about 50% of cystinosis patients experienced fractures at some point of life. So what is Rickets? Renal tubular disorders, as Fanconi syndrome, is an important cause of Rickets, and indeed it accounts for 1/3 of all causes of Rickets now. It's associated with renal loss of minerals, calcium and phosphates. And Rickets and osteomalacia is more common in Fanconi syndrome when compared to other causes of renal tubular acidosis. Can be multifactorial and indeed is multifactorial. Young patients with early phase of cystinosis, let's say they have nutrition deficiency because of the poor feeding, frequent vomiting, and other GI issue retaining the dietary content of minerals. Children could be phosphatopenic, that means a low phosphate level in blood, calcipenic with low level of the blood, and we encountered to such group of patients. Vitamin D deficiency could be detected in our patients as well. Again, due multiple issues such as a lack of absorption and metabolism because of the renal disease, kidney disease. Now we recognize, and not only in cystinosis, that the role of low dietary calcium intake in pathogenesis of Rickets is greater maybe than we originally thought. And I think many of us heard now, and it's becoming more and more prominent in the social media and in scientific literature, that vitamin D deficient Rickets, regardless of the calcium and phosphate loss, is becoming more global health issues nowadays compared to a few years ago. Just a brief overview: calcium and phosphate metabolism in Fanconi syndrome is filtrated in the beginning of a nephron and glomerular. About 60% reabsorbed in proximal tubule, which is defective in cystinosis patients, and remaining in the distal tubule and convoluted tubules. Generally, it's agreed that rickets and osteomalacia results from low concentration in calcium and phosphate in body fluids and consequently in the bone tissues. The role of chronic acidosis is important in the mechanism of the formation of a poor bone mineralization, and we know many of cystinosis patients indeed acidotic if improperly treated, but I think the community is doing a good job in that. Most of the serum or blood level calcium is generally normal, although in severe cases, we all know that could be calciopenia, and particularly the role of ionized calcium detection is very important to identify such patients. Hypophosphatemia is more frequently present. Alkaline phosphatate in poorly treated or in initial diagnosis could be highly elevated, but also could be just borderline elevated. PTH, as we discussed yesterday and today, Dr. Elenberg mentioned, could be normal. Sometimes could be increased. In many cases, it's lower compared to a general population with renal disorders. And it's generally been accepted for many years that rickets or Fanconi syndrome and cystinosis resembles genetic hypophosphatemic rickets, and this is how it was treated, successfully treated for many years. Yet we encountered still problems and deformities that causing significant disabilities to younger patients and, of course, to patients with long-term disease. Briefly mention, maybe as a reminder to medical community, when in the past for diagnosis and treatment of rickets, the calcium phosphate product been used, and normally supposed to be more than 30. The serum calcium and multiplication of serum phosphate levels in rickets and osteomalacia, it's less than 24, and it's still reliable index if help of rickets needed. So as mentioned before, rickets is a defect of mineralization. Important to remember, rickets is a disease of a growing skeleton. When children achieve puberty, we cannot diagnose and give them diagnosis of rickets anymore. Rickets is a problem near joints because the bones formed by the growth plate does not mineralize properly. When the growth plate becomes thick, wide, or irregular, that could be seen in children, and you've probably seen in young children and toddlers, like thickness of the wrist and knees. But it could be no longer seen in adults when don't have growth plates anymore. But abnormal joint could persist later into the adulthood. Bones could be painful, and I think some parents know about the children either refuse to walk because of the painful joints, and we know some families with children simply crying, complaining of legs pain. And again, sometime diagnosis, if it was not identified early with mild presentation, because the children simply refuse to walk or delay ambulation in such children. Some teeth problems, and patients again are often short, of course. So what is the mechanism of this thickness around the joints? In normal circumstances, the hypertrophic chondrocytes undergo apoptosis because of enough calcium and phosphate ions. If there is not calcium and phosphate ions delivered to chondrocytes around the joints, there is no apoptosis occurred, and you see the rachitic growth plate seen, and it's called bracelets in cystinosis patients. And here is a brief scheme how the rickets presents in young patients. It could be a large head with prominent forehead, lumps occurring on the chest called rosaries, and again bones could be painful. So how Rickets look in cystinosis patients? This is a reference from the archives of the diseases of childhood. Like again, radiological data, radiological presentation, thickening of epiphysis here, and cupping of epiphysis. I don't know if you see by the mouse pointing. Wide metaphysis, mostly on the knees. Bowing of the diaphysis as well. Here we see kind of prominent bowing of the tibia. And for some reason, most because maybe muscle involvement of our patients, young patients, they have this X looking deformities of the knee called valgus. And this is why it may be cause also a kind of a little bit of, because of muscle weakness and ligament weakness, subluxation of the ankles a little bit, called pronation and feet deformities that many children have. Osteomalacia, I probably would skip a little bit. It's mostly detected in patients who are older, could be spontaneous fractures, not identifying painful femoral fractures, and some deformities in spine. What is Rickets of Fanconi syndrome? And again, there is some arguments continued. Traditionally been named as a hypophosphatemic rickets due to the large loss of phosphate and low serum phosphate, but we found retrospectively and now prospectively that calcium also lost in large proportion in such patient. So possibly now, and it will take time for consensus and of course more strong data and publications, possibly that rickets of cystinosis more resemble hypophosphatemic rickets with hypocalciuria, with such well-defined genetic disorder. So what we found of data on hypocalciuria. Hypocalciuria is increased excretion of the calcium in the urine and needs to be calculated in better in 24 hours urine collection. So we looked on 36 pre-transplant patients who didn't need either dialysis or were not on the list for the transplant yet. So 33 out of 36 were not on any calcium therapy, only 3 been on the calcium therapy. Radiologically, data of rickets or osteopenia been confirmed in all 36 patients reviewed by 2 independent radiologists. Skeletal deformities of the different varieties been presented in all patients. Phosphate therapy been addressed much better. 28 patients been nicely and diligently treated with phosphate. Only 8 patients been untreated, maybe discontinued the treatment. Vitamin D therapy been more or less addressed better. 20 patients been treated with vitamin D therapy, and 16 patients didn't have any vitamin D supplementations. And again, that is a group of a patients that's coming all over the country. It's not specific center of a hospital, not specific doctor, and just patients from all over the United States coming to NIH on natural history protocol. Phosphate therapy that come to the doses been ranged between 250 milligram a day to very good doses, 1500 milligram a day. I didn't present phosphate excretion data because patient been mostly on phosphate supplementation, but now prospectively we are trying to look in such population, just simply discontinuing phosphate for a couple of days while we're at NIH to calculate what is the true loss of phosphate with urine. And vitamin D therapy was given either in suboptimal doses, such as ergocalciferol 400 units, just a prophylactic dose, to very good calcitriol doses of 1 microgram a day. Hypercalciuria now patients, just a brief reminder how it's defined in children. Urine calcium to creatinine ratio could be either in spot urine or 24 hours urine. Usually considered above 0.2. I need to state that in infants, this range is allowed to be a little bit higher, maybe more than 0.3 or 0.4. But in our group, we did not have infants. As we know, the cystinosis patients diagnosed around around between 12 to 16 months of age. We really didn't have infant collections. Maybe prospectively we will have now, because we have SIBS diagnosed early and we can do collection. Hypocalciuria ranged, and again, the other number is normal, is like 4 milligram per kilo per day, with maybe more precise definition of a normal calcium excretion. In our patients, levels are being of very broad spectrum between 0.4 when it comes to calcium to creatinine ratio to 3.8, which is very, very, very high proportion, or between 6 to 13 milligram per kilo per day. And again, patients were not on calcium supplementation at that time. Most of the patients been normocalcemic, and because probably just maintain life homeostasis, as we know that hypocalcemia is life-threatening disorder, maybe coming out of the bones just to maintain normocalcemia. 6 patients, although, been hypocalcemic, they are young patients, and been asymptomatic. Been difficult to collect all retrospective data because most of the outside records were not available. But I need to state that 2 patients had severe tetany. 1 patient required almost monthly admissions because of tetany, despite on large calcium supplementation and milk formula feeding. So what is radiographs of our young patients? With our patients, you see the deformities of the knees with white metastasis, quite osteopenia radiologically defined, deformities here of the femurs, beginning of the scoliosis, and again osteopenia on the spine. There is a generalized osteopenia in very young child, and again some osteopenic femurs with some valgus deformities that are toddlers. This is pictures of toddlers. Older children between maybe 7 to 12, again, we still see deformities of the knees and radiologically wide metastasis. Osteopenia in a child who probably about 10 years of age. Here is ankle deformities that many parents are well aware that our children have, like again osteopenic spine, and there's here some rickety changes in the wrist and the ulnar deformities. That is real patients of us. Patients with severe osteopenia, adolescent patients between maybe 12 and older, 12 to 16. Severe osteopenia described just on the skeletal surveys. Here, osteopenic femur and tibia. Severe skeletal deformity in the child who was really, really poor treated. He's 13 years old. He has severe scoliosis. And again, generalized osteopenia in a 15 years old child. So I think I would like to bring your attention to the lessons that we learn about hypercalciuria in other disorders, mostly maybe idiopathic hypercalciuria, which is not well defined, but there is still publications that bone mineral density had consistently decreased this cause for children with idiopathic hypercalciuria. And again, that is generally healthy children without systemic genetic disorder, just with hypercalciuria, with normal diet and normal milk intake, but they have a decrease as this cause in lumbar spine and to lesser extent in the femoral neck. In untreated patients with obligatory urine calcium loss relatively unaffected by diet as a renal leak, hypercalciuria, or renal phosphate lack, and resorptive hypercalciuria also developed a negative calcium balance that results in osteopenia and osteoporosis. 2 other publications, again in the patient's idiopathic hypercalciuria, you see how progressively with age, when the patient's becoming older, the Z-score is falling, becoming below 2.5 and 3. We have some patients, adolescent patients in our community who has Z-score about -3 and -4. And now, like I need to state, we are trying universally to perform DEXA scan to define natural history of a bone disease in cystinosis patients. The data will be available. Here is a review, meta-analysis of review publications of patients in primary hypercalciuria. It's about 15 publications here, and you will see that bone mineral density universally decreased in the patients with long-term primary hypercalciuria. So references, what is a calcium in our body? 99% in the bone. Dietary needs, I need to state here, in healthy children, kids need 600 milligram a day, and we all hope they all get it from the diet, mostly milk or formulas. Adolescents, because of the rapid growth of the skeleton, about 1,300 milligram a day. Adults a little bit less, and of course pregnancy and breastfeeding much more. Patients with frequent fractures needs more, about 1,500 milligram a day. Calcium mostly absorbed in duodenum by active transplant and jejunum and by diffusion. Mostly reabsorbed, as I showed before, in proximal tubula and some excreted in stool. So what we propose now, based on our recent data, and we are following now the outcome, starting to treat patients with calcium and phosphate. Some patients, and again, we calculated the need, the dietary need of a child, and plus calculation of the calcium loss in the urine, to make sure there is no negative balance, and the calcium required, and our nutritionist helped to calculate how much calcium the child gets by G-tube and milk supplementation, and how much supplementation is needed in the form either of a liquid or the pills, ranges between 1 to 3 grams a day in some patients. Phosphate therapy remained to be in acceptable ranges, although some patients required about larger doses, particularly the patients who've been late diagnosed and they had severe Fanconi syndrome with large urine losses. As you know, larger urine losses are larger minerals and electrolytes loss. Important to remember for parents and maybe for some primary physicians in a busy practice, that calcium and phosphate never should be given together, because calcium and phosphate binds for hydroxyapatite, and it just excreted in stool and doesn't get absorbed and delivered to the blood circulation. Vitamin D calcitriol been successfully applied to children between 0.5 to 1 microgram a day, and again it is all disputable and needs to be customized to each patient based on a clinical presentation, and we are measuring vitamin D level in our patients as well. I think the community of nephrologists appropriately concerned about monitoring of the possible calcium depositions in the vessels and the kidneys. Nephrocalcinosis is a part of cystinosis itself, not necessarily because of their own mineral supplementation. Sometimes echocardiographers who doing kidney ultrasound describe as nephrocalcinosis. Maybe it indeed just decreased echogenicity because of a cystine deposition. But by our observation, when we looked on the glomerular filtration rate and creatinine levels in the patient who has nephrocalcinosis and patient who does not have nephrocalcinosis, renal function being equivalent. So in few patients, hypercalciuria significantly improved after initiation of calcitriol therapy, possibly because not all hopeless loss of the function in the proximal tubules, and we know that 125 dihydroxyvitamin D acts on the proximal tubule and improve reabsorption of the calcium and maybe gut absorption. Data collection in the process. DEXA scan now is performed in a large majority of the patients and continue to be performed, and showed a reduced bone mineral density. Therapy, there is one example of a patient, young, 3 years old. You'll see the Rickets changes in left hand that significantly improved after 3 months of supplementation with calcium, phosphate, and vitamin D therapy. There is a data, it just publications, old publication, because there is not enough really data been published so far in treated patients, outcome of treated patients in cystinosis that come into mineral supplementations and vitamin D, but here is few, and this is the figure here, the patient who improved on supplementations on phosphate and vitamin D metabolite, and all the child the same, before the treatment and after treatment. It's old publications. So what our proposals, now we know that all our young patients have renal Fanconi syndrome, leading to the loss of the minerals calcium and phosphate. If it's not appropriately treated with supplementations, it leads to rickets, osteomalacia, and misfortune deformities, which is difficult to fight, called disability to young children, and more disabilities to older young adults. So now we would, when we became aware about small to moderate but chronic loss of bone mineral not recognized by laboratory studies in the past, such as serum phosphate calcium, alkaline phosphatase, can produce devastating bone disease. And I would like to refer to the phrase of Bill Gall, because he always compare, even in a small negative balance, maybe over 10 years, can cause significant decrease of mineral density, causing to the rapid developing deformities during the puberty spurt, and even fractures in patients. So we proposed, because that natural history study protocol supported by NIH and Human Research Genome Institute, to include team of nephrologists, will be very thankful to address all discrepancies in the treatment, to avoid possible complications. Geneticists, bone specialists, and now I think we're successfully approaching to include orthopedic doctors, radiologists, as well. So there's a few testimonials now. Let's say when there is an argument to start calcium, with patients being just on phosphate treatment, but been sent by the parents before our girl was on calcium and phosphate and vitamin D. She was sluggish, she had no energy, she was always tired, and she complained a lot about her bone hurting. She didn't sleep well, her skin was very pale in color. After eating the supplements to her daily regimen, her energy levels through the roof. She has color liveliness, she hasn't complained but maybe one time about her legs hurting, and now she can run and be active. Asking the question and answering to us, yes, a lot of better. Just in last 2 weeks, his pain, it's again a small child, went from 6 to about 2 to 3. We are getting new orthotics for physical therapists. Like, again, important, please address it with your primary doctor, if needed, physical therapist. And again, please incorporate rehabilitation doctors. They are available. They'll be happy to see patients with skeletal deformities. And there is a muscle disease that also contributed probably to the bone and muscle unit dysfunction as well, could be addressed by exercise and physical therapy. Some references. I would like to thank you, patients and families, that now we kind of bonded and know well. Of course, Dr. Gall supporting the project. I would like to give special acknowledgement to our wonderful coordinator who was not able to come here, Joy Bryant, who helps enormously to communicate patients on all parts of the country, diligently, timely, and just helping. And I think some of families would agree with that. Dr. Tosi, who is a wonderful orthopedic doctor who sees cystinosis patients in Children's National Center for many, many years, and given just nothing but wonderful advice how to approach if surgical treatments are needed. Dr. Bullis, who reviewed the radiographs of our patients, also from Children's National Medical Center. Dr. Kaskel, for supporting on ideas and giving some proposal for future development of the projects, and of course CRN for supporting us in that regard. Thank you again.
Thanks to Dr. Nesterova for that talk. She's been a really strong advocate for the recognition of these issues for many years in cystinosis, and continues to work for better diagnosis and treatment. So we thank her for that.